Well, thank you all for joining, and welcome to today's event. My name is Ativ Mehrotra. I'm the chair of the Department of Health Services Policy and Practice at the Brown School of Public Health, and I'm excited to have you join this seminar, which focuses on private equity. Private equity firms have made huge investments in healthcare across so many sectors, from hospitals to physician practices, home health to palliative care. Unfortunately, growing research has highlighted how PE acquisition can negatively impact the care that Americans receive. And this has led to many proposed and laws and new laws that try to curb PE acquisition and or curb problematic behavior of PE firms. We're excited today to host a virtual event focused on exploring the impact of PE on health care. Health Affairs has collected a panel of experts to discuss some recent research published in Health Affairs on PE and its implications for healthcare clinicians, communities, and patients, and what state and federal policymakers can be doing in response to PE's increasing role in healthcare. Today's discussion is based on insights from recent articles in the Practice of Medicine series, which have been supported by the Physicians Foundation and for which I'm the series advisor. We are grateful for the foundation for its support of our work. Before we begin, I want to emphasize that questions can be submitted through the Q&A tab at the bottom of the screen, and I'll be monitoring those and raise those questions with either the first or second panel we'll have today. So let's get started, and let me first start by introducing Dr. Price. Gary Price is a board member and the current president of the Physicians Foundation and a board-certified plastic surgeon. Dr. Price is a past president of the Connecticut State Medical Society and the Connecticut and New England Societies of Plastic and Reconstructive Surgeons, and he holds an MBA from the Yale School of Management. Dr. Price.
Well, just to reiterate, greetings again. Private equity investment in healthcare has accelerated over the past decade, as you've heard, spanning hospitals, physician practices, home health, and more. Proponents often cite potential benefits such as access to growth capital, modernized technology, and administrative support that can ease practice burdens. But as physicians, we're also seeing the other side of the ledger: higher prices for patients, reduced competition and choice, increased administrative demands, and diminished autonomy. These pressures reverberate across our workforce and ultimately at the bedside. The Physicians Foundation exists to empower physicians to lead in delivering high-quality, cost-effective health care. And we hear clearly from physicians that consolidation, whether via hospital acquisition, insurer ownership, or private equity control, is reshaping the practice environment in ways that too often sideline medical judgment. That loss of autonomy is not an abstraction. It's a major driver of burnout and a barrier to the patient-centered care our communities deserve. Our recent research underscores this reality. In our 2025 National Survey of Physicians on Practice Environments, we examined perceptions of autonomy and the impact of corporate policies and insurance regulations on day-to-day care. The response was unambiguous. Physicians feel mounting strain from non-clinical demands that conflict with their professional obligation to put patients first. This misalignment erodes morale and threatens retention in a workforce already under stress. We also hear consistent calls for guardrails. In our ongoing work with practicing physicians, strong majorities support safeguards to ensure any consolidation serves patients and preserves the integrity of medical decision-making. These include preserving physician autonomy, maintaining patient care standards, increasing transparency and disclosure, assessing long-term impacts, not just short-term financial returns, and closely monitoring financial practices. These priorities offer a practical roadmap for policymakers and health system leaders to ensure that capital and care are aligned. Today's program brings together leading researchers and clinicians to examine the evidence and illuminate where policy should go next. Together, they will explore the latest research on private equity's footprint in healthcare, its implications for clinicians and patients, and the levers available for federal and state policymakers. What do we hope to accomplish? First, clarity, an honest accounting of where private equity supports care delivery and where it undermines it. Second, consensus, agreement that physician leadership must be embedded before, during, and after transactions that reshape care. And third, commitment to transparency, long-term quality and access, and to keeping medical judgment rather than purely financial imperatives at the center of care. This is not about being for or against investment. It's about aligning financial models with the mission of medicine. Physicians are ready to lead in that alignment. We ask policymakers and capital partners to meet us there by engaging physicians early, evaluating downstream effects on patients and communities, and building durable safeguards that protect both quality and affordability. Thank you to Health Affairs for convening this important conversation, and to our panelists for bringing data, rigor, and on-the-ground perspectives. Most of all, our thanks to the physicians and care teams who continue to deliver for patients amid rapid change. Their commitment is why this discussion matters and why we must get it right. I'm looking forward to a robust, solutions-oriented discussion. With that, let's begin.
Well, thanks so much, Gary. Today's session is going to be divided up into two parts. The first panel, and I'll be introducing all four of our panelists shortly, will be focused on highlighting new research that's come out in health affairs on the topic of private equity. After some Q&A with those panels, we're going to turn to a second panel to discuss in more depth some of the implications of that research and the policy implications. So let me first by introducing our four speakers for the first panel. The first is Yashaswini Singh, who's an assistant professor of health services policy and practice at the Brown University School of Public Health. Second, we have Sneha Kannan, who's an assistant professor of critical care medicine at the University of Pittsburgh. Third, we have Ola Abdelhadi, who's a research scientist at Stanford Medicine. And last but not least, Stephanie Lee, who's a medical student at the University of Michigan. Let me turn it over to Yashaswini.
Thank you very much for having me. My name is Yashaswini Singh. I'm an assistant professor at Brown, and I'm really delighted to kick off today's panel. I wanted to start where we left off, just level setting a little bit about the current landscape of physician organizations in the United States. Just in the last 5 years, we've seen an acceleration of corporate entities employing physicians. 6 in 10 physicians were employees of hospitals, health systems, health insurers, or private equity firms as of 2019, and this has accelerated to 8 in 10 physicians as of last year. Now, there are a variety of entities responsible for reshaping these trends, predominantly mergers and acquisitions led by health insurers, hospitals, and health systems, but by far the dominant factor here is the growth of private equity investments in healthcare. We see from the graph on the right that M&A activity just in the last 5 years for physician practices, over 2/3 of reported mergers and acquisitions of physician practices have been led by private equity firms. So while there are a whole diverse host of entities reshaping physician employment, PE in particular is the dominant one in recent times. Next, please. Given this, I thought it would be helpful to lay out how the classic model of PE investments in physician practices operates, at least from a research standpoint. I will say before I get into this flowchart is that there is no such thing as a classic model, because if you've seen one PE transaction, you really have seen one PE transaction. But nevertheless, there are some defining attributes of PE that are helpful to understand in the broader context of consolidation. PE firms generally raise capital from institutional investors, combine this capital with large amounts of debt, and use this combined investment asset, the PE fund, to make a majority stake investment in a physician practice. Depending on the state regulatory environment, this majority investment can be facilitated by the use of a management services organization, which I know my panelists will discuss later on as well. A platform practice could represent a large practice with great brand recognition and loyal stream of patients. In this illustrative example, the platform practice constitutes 3 physicians in one local market. What is distinct to PE, in contrast to other types of consolidation activity, is a platform and add-on model of consolidation. So once again, what starts out as an initial acquisition of one practice with 3 physicians is followed by a series of smaller add-on acquisitions, which enable the PE firm to gradually increase market share in a way that evades antitrust scrutiny. So again, back to the example on the slide, An initial platform practice acquisition of 3 physicians is followed by add-on acquisition of practice A with 2 physicians, practice B with a single practitioner, and practice C with 4 physicians, giving the PE firm control over 10 physicians in a local market, even though each of those 4 transactions do not individually require any reporting. Importantly, PE firms invest with the incentive to exit over short time periods or resell their investment in a pre-specified time period. A research I published in Health Affairs Scholar last year shows that theoretically exits can take the form of an IPO, a sale to another private equity firm through a secondary transaction, or sale to a corporate entity such as Optum or a health system affiliate. Theoretically, these are possible, but by far the dominant strategy to date is that of a secondary buyout where PE firms sell invested practices to other PE firms. I like to highlight this slide to show how the model operates, but also to highlight that no part of this flowchart at present has any systematic reporting or disclosure requirements, either to federal or to state regulators or authorities, making it really difficult to understand PE penetration and its impact on patients and healthcare workers. Next slide, please. For the remainder of my time, I wanted to highlight 3 studies that we published in Health Affairs in the past year, each highlighting 3 distinct policy concerns that emerge from PE's growth in physician practices in particular. For the first study, I wanted to highlight a paper we published in the February issue. Now, this study focused on PE's effects on healthcare affordability. There is a growing body of research now that has shown that relative to independent practices, private equity acquired physician practices increase commercial prices in the ballpark of 0 to 70%. So it really depends on the clinical service and clinical area you examine. In contrast to prior work that largely has examined independent practices as a control to PE acquired practices, this study pictured on the left, we compared PE acquired gastroenterology practices to those that are affiliated with hospitals and health systems, and found that even relative to these types of entities, PE-acquired practices increased negotiated prices by commercial payers by 28%, and largely this was driven by increases in physician professional fees. So this study is sort of a contribution to this growing body of research that has documented consolidation concerns and emerging concerns related to healthcare affordability. I also want to highlight that my colleagues have done great work highlighting changes to quality metrics following PE acquisition and have found largely in the physician practice domain, no changes emerge. And so coupled with that finding, the fact that PE increases prices by upwards to 70% in some specialties raises concerns about the value of care that is being delivered at these practices. Next slide, please. The second study I wanted to highlight here was published in the April issue of Health Affairs this year, specifically looking at what PE acquisitions mean for patient care and patient access. In particular, PE's emphasis on short-term profitability can change service provision based on the relative profitability of services. These are concerns that have been documented in hospital settings and paring down of obstetric wards and other maternity wards at hospitals. In this study in particular, we honed in on a particular surgery, retinal detachment repair, which is a key example of an emergency condition for which disease burden and profitability diverge. If surgery does not happen within days of diagnosis, you can go permanently blind. And in particular, some studies have highlighted that Medicare reimbursement is not sufficient to cover the cost of providing these services. So in the study, we wanted to examine what happens to the provision of this particular surgery after PE acquisitions in ophthalmology in subspecialty retina practices in particular. And we found that following acquisition, over 2 years after acquisition, there was a 20% decrease in the provision of these critical but perhaps less profitable surgeries. We also documented a lot of these reductions were in patients that have diabetes and hypertension, common chronic conditions that can lead to serious complications if immediate care is not delivered. So this study is one example of findings that raise concerns over diminished clinical autonomy and whether financial interests ultimately shape the care that is provided at acquired entities. Next slide, please. For the last study I wanted to highlight today, I wanted to summarize a paper we published in the March issue of Health Affairs. And here we honed in on the implications of these trends for the healthcare workforce. In a prior study led by Joe Bruck that we published also in Health Affairs a couple of years ago, we documented that PE-acquired practices increase their reliance on advanced practice providers such as nurse practitioners and physician assistants, perhaps reflecting PE's need to cut costs as a way to drive profitability targets. In the current study, we documented increases in physician turnover, or the share of physicians who quit PE-acquired practices in each year after acquisition. The baseline turnover rate was around 5% at practices before they became acquired, and this increased to over 20% after acquisition, an increase of over 265% relative to baseline. We also documented that a lot of these physicians exiting practices tended to be younger than 60 years old, so this is not the case of physicians simply retiring after selling their practices to private equity. And importantly, physicians who quit PE employment moved over 100 miles on average in search of alternate employment. Together, these findings raise concern about workforce effects. In particular, PE's platform and add-on model of consolidation can reduce the availability of non-PE employment in certain local markets. And these findings are also consistent anecdotally with extensive use of restrictive non-compete agreements, which can make it difficult for physicians to leave undesirable employment conditions or find alternate employment. Next slide. For my last slide here, I wanted to highlight, I shared with you 3 papers, each ties to a specific but distinct policy concern. And I wanted to leave this slide with you for discussion later to highlight policy approaches that are specific to the policy concern. So if the concerns around private equity are more around consolidation and the platform add-on model of consolidation, then policy remedies that are appropriate are related to federal antitrust enforcement, and increasingly states have played a larger role here. However, if the concerns that concern you the most are related to professional autonomy and interference with clinical judgment, antitrust enforcement is not the appropriate tool here. Rather, we are looking at ways to strengthen the corporate practice of medicine. Finally, underpinning all of this is a desire for greater transparency, given the opacity and lack of accountability that PE firms bring to healthcare transactions. Ownership transparency is really essential to further the conversation around how we can harness capital for improved patient care and healthcare workers. Thank you for having me.
Thanks so much, Yashaswini. Let me turn it over to Sneha.
Hi, everyone. Thank you so much for having me. I'm Sneha Kannan, Assistant Professor of Critical Care Medicine and a practicing ICU physician. So the broad highlight of my talk is going to be how unique are PE firms, with a focus on hospitals. And specifically, I'll be highlighting results from a paper published in February of this year, studying variation in how hospitals spend money on salaries, so salary expenditures, and utilization, how much are they charging patients, basically how much care are they providing. Next slide, please. So the sample we looked at, the characteristics are here. We looked at 242 hospitals newly acquired by private equity, matched to a little over 800 hospitals on these characteristics above. I'll highlight that most of these are for-profit hospitals that were acquired by private equity. Most are in the South, so they are regionally concentrated, and most are small hospitals. Next slide, please. So this slide looks at differential changes in salary expenditures in millions of dollars at private equity hospitals compared to control hospitals. At the top, or I should say on the vertical axis, you see firms. So the top HCA is the Hospital Corporation of America, which is the sort of quintessential first large private equity acquisition of a hospital system. It happened in 2006. And you can see that the green dot there doesn't deviate too far from zero, in that HCA hospitals did not change how much they were spending on salary expenditures compared to control hospitals. The rest of the firms, however, all of those dots move into the negative. And what this graph ultimately says is that firms 1 through 7, as well as the other category, which has 4 other firms in it that only acquired 1 or 2 hospitals, all of these firms on average reduce salary expenditures anywhere from $26 million to closer to $5 million compared to control hospitals. Next slide, please. And this looks at variation by firm and department. So if we take that graph that I just showed and break it down by clinical department, the green is showing where salary expenditures increased at private equity hospitals. The red is where salary expenditures decreased. The numbers inside these numbers are normalized to be a percent change of baseline. So for example, at the very bottom, the dark red 187%. That basically is saying firm 4, on average, in their outpatient clinical departments, reduce salary expenditures by almost 200% of their baseline compared to control. What you can see here is that there is quite a bit of red. The little asterisks signify, statistical significance. But in general, there are some green spattered around. HCA, consistent with the prior graph, doesn't seem to change salary expenditures very much. But across the firms and across the departments, there is a fairly uniform, I would say, reduction in salary expenditures. The question becomes, are people just being paid less, or are there fewer people? In other analyses in this paper, we've showed that it was likely that there are fewer people. Next slide, please. So for that reduction in salary expenditure, reduction in staff, what are hospitals actually delivering? And so this looks at cumulative charges. We can't, unfortunately, observe how much a hospital is paid for their services, but we can see how much they're charging. And that is a function of how much care is provided, the quantity, as well as the price. I will say across the board, for the non-HCA firms, the price does not change. However, for HCA, where the charges are going up relative to control, the price did change. Whereas these other firms, the price they charged didn't change, but the amount charged decreased, suggesting that there was less care provided. Next slide, please. And similarly, we see something consistent by department, where all the departments or many of the departments had reduction in salary expenditures. We see a similar reduction in charges. HCA has a strong green column there. And in other analyses, as I said, that's likely because the price charged rose. So what do we do with these data? Where do we go from here? The goal of this analysis was to see how varied private equity strategies are in their hospitals. One point we see and we hear made relatively often is that private equity acquisitions are not monolithic. To an extent, that is true. In hospitals, there is some variation. Some firms may strategically choose to reduce staff more in some departments versus other departments. These graphs show some heterogeneity. But on the other hand, firms 1 through 7, plus the firms and other, that's 11 or 12 firms represented there, they all have a similar global strategy of reducing staffing. And the consequence seems to be that there's less care provided. In other analyses that I, along with my team members, have done, we've showed that that reduction in staffing has implications for patients. In one analysis a couple of years ago, we showed that there was a rise in hospital-acquired conditions or complications, likely due to a reduction in staffing. In a more recent paper we published, we also showed that there was an increase in transfers as well as an increase in mortality amongst patients only treated in the emergency department, alongside departmental staffing reductions. And so whether or not private equity strategies truly differ is, I suppose, a little bit up to the reader, up to interpretation. However, if you ask me, looking at these data, it seems like the strategy of staffing reductions is fairly consistent. And healthcare is a very human endeavor. It's a very labor-intensive field. And you can see it with some of these reductions, as well as other work that we've done, those reductions do have consequences to patients. Thank you.
Thank you so much, Sneha. Let's turn next to Ola.
Hi, everyone. Today I'll be presenting our research on private equity acquisition of physician practices and market penetration from 2012 to 2021. So private equity ownership of physician practices increased substantially from 2012 to 2021, resulting in higher market penetration, local concentration, especially in recent years from 2019 till 2021, as we can see here in the map. These raise an important policy questions and around cost and competition and care delivery. So our research goal here is to provide data that can help inform regulatory oversight and competition policy. So supporters argue that BE brings capital, technology, and efficiency. On the other hand, critics worry about higher prices, lower quality, and reduced competition. But one question remained unanswered. Next. So this question is, how much market share does private equity actually control in local physician markets? So our study sets to answer this question by quantifying not just how many practices were acquired, but how much market power BE firms hold at the physician level across metropolitan statistical areas. And to do so, we first identified the acquisition from the data from 2012 to 2021 using multiple data sources. like PitchBook, Irving Levin, and other supplemental data, and linked these to acquisition physician data from SKNA and IQVIA across 10 specialties: dermatology, gastroenterology, OB/GYN, ophthalmology, primary care, oncology, orthopedic, cardiology, radiology, and urology. And final step is that we calculated the market share using full-time equivalent physicians in each specialty within each metropolitan statistical area. And for concentration, we used the Herfindahl-Hirschman index. So this approach let us move beyond simple counts to much more powerful metric: who controls the physicians in local markets. And for the results, next please. For the results, we found a massive BE expansion in acquisitions from 2012, 816 acquisition to 5,700, more than 5,700 acquisition in 2021. Not only that, BE presence spread across multiple metropolitan statistical areas to reach to more than 300 metropolitan statistical areas in 2021. And as you see here in this curve, while acquisition dipped in 2020, there was rapid growth after COVID as the number of acquisitions surged to reach more than 300 acquisitions in 2021, which was the highest in the decade. So the increase in the acquisition was associated with increase in market penetration. Some specialty were particularly targeted, like gastroenterology, where it reached to 13.1%, dermatology reached 11.1%, urology reached 9%. So one of the most important finding is that BE firms control substantial portion of local specialty markets. For example, BE firms held more than 30% market share in 120 MSAs, and more than 50% market share in 60 of those MSAs. Even more striking, a single BE firm sometimes dominated. In 108 MSA, a single BE firm held more than 30%, and in 50 MSAs, a single BE firm held more than 50%. These levels exceed common antitrust concern thresholds. And this concentration was more pronounced in some specialties like gastroenterology, dermatology, OB/GYN, and ophthalmology. And geographically, it was more concentrated in the south and northeast. We followed up by study in oncology acquisition to find that these BE acquisition continued to increase in 2022. Next, not only that, it also led to increase in oncology prices. Same in the following slide, you will find increase in gastroenterology prices in a study led by one of my co-authors, Dan Arnold. And next, why does all of this matters, and what does this mean to patients and clinicians? So BE investments can improve operations, technology, and financial stability, but high market concentration carries some risks, including reduced competition, higher prices, pressure for short-term profit through increased volume or increased charges, workforce changes, as we saw, potential quality impacts. These changes often occur without public visibility because many BE acquisitions fall below federal reporting threshold. So to summarize, in just 10 years, private equity has become a major force in physician practice ownership, often holding dominant market share in local specialty markets. Private equity presence in many of these local areas control 1/3 to 1/2 of specialty physicians. This trend raises important questions about competition, price, patient care and quality, and health equity. And also it highlights the need for close scrutiny by federal and state regulators, especially in these highly concentrated markets.
Thanks so much, Ola. Let's turn last to Sneha. Stephanie, excuse me, who's going to discuss some of the state interventions that have recently occurred.
Amazing. Thank you so much. It is an honor to be here to present our article on private equity in healthcare through a state-based lens, which was published on Health Affairs Forefront. Next slide, please. We first wanted to start by discussing why we chose a state-based lens rather than a federal lens, and this is largely due to states having a more active role in implementing policies to monitor or regulate PE, and this is in part due to the federal government reviewing deals with values of at least 126.4 million as of 2025, and most PE healthcare acquisitions fall under this threshold, so states have played a central role in managing PE. Next slide, please. Thank you. There are two policy approaches we discussed in our article, the first being transparency laws and the second being corporate practice of medicine laws. For the first policy approach, transparency laws, these laws require notification or approval of PE healthcare acquisition to state entities, and the level of detail required in the notice depends on the state, and these notices generally are required between 30 to 60 days prior to closing a deal. In this figure, we can see that 16 states do not require notice or approval to the state, 6 require state entity approval, and then 30 require notification. We wanted to give an example of a state that required state entity or attorney general notification, and that state is Massachusetts, which already required healthcare companies to notify the state 60 days before big mergers or acquisitions. But this law kind of mainly applied when two healthcare entities, such as two hospital systems, merged. This year, Massachusetts just passed a law which requires notification for any PE investment that changes who owns or controls a healthcare provider. And in this law that was passed, there were some other notification criteria, including significant expansions in a provider or provider organization's capacity, as well as mergers or acquisitions of provider organizations that result in provider organization having a dominant market share. The second policy approach we discussed was the corporate practice of medicine law, which are state laws that limit non-physicians from owning or controlling medical practices. And although the implementation of the CPOM laws vary by state, these laws aim to promote and maintain the patient-physician relationship. In this figure here, we can see that 17 states have no CPOM laws, 11 have CPOM laws with no exemptions, 4 with nonprofit exemptions and corporate physician independence exemptions, and then the last one being 22 states with CPOM laws with nonprofit exemptions. So you may ask, how do private equity firms continue to acquire clinics in states with CPOM laws? And Dr. Singh briefly mentioned this in her presentation. Some private equity firms do this by using the friendly private corporation arrangement or loophole. So under this arrangement, a physician-owned entity, otherwise known as a private or friendly private corporation, will administer medical services and employs the healthcare professionals at that acquired clinic. And at the same time, a management services organization, which is private equity owned, will offer non-clinical support such as administration or billing to the friendly private corporation. And the friendly private corporation will pay the MSO for their services. In response to this sort of arrangement or a loophole, some states have actually passed laws to address this. An example of a state that has done this is Oregon. This year passed Senate Bill 951, which prohibits dual ownership. So management services organization shareholders, directors, or officers cannot own majority stakes in a professional medical corporation they manage. And additionally, this law prohibits MSOs from exercising, quote, de facto control over clinical decision-making, staffing levels, billing policies, and payer contract negotiations. This law is unique as it gives Oregon the power to block transactions that actually violate the law. And then this leads us into our last slide on what are the future policy implications that were discussed in our article. There were 3. The first being that policymakers should consider increasing transparency requirements to help states determine the impact of private equity transaction on their healthcare market and medical care for patients. Secondly, policymakers should consider regulating transaction to align private equity goals and patient outcomes. So, for instance, if reduced cost is a priority for both PE and patient outcomes, policymakers can consider monitoring potential anti-competitive effects of private equity acquisitions through potential transaction regulations, which would help reassure patients and payers that costs would not increase. And then lastly, policymakers should consider implementing and enforcing CPOM laws to reduce pressures on clinicians in private equity-owned practices or hospital to reduce the pressure of prioritizing short-term revenues over patient care. Thank you.
Thank you, Stephanie. Really appreciate it. And if we could have the other panelists come back on board and we can probably shut down the slides. So we have about 12 minutes here that we can focus on questions. And I'm going to be both building off a lot of the questions that have been put up in the Q&A, and I encourage those participants to continue to add questions there. Yashaswini, maybe I'll start with you first. One of the themes of the questions, you've heard it 100 times when it comes to this area is, well, is this a PE phenomena? Or are we seeing the same kind of action through other kinds of acquisition and, this broader phenomena of corporatization? So I wonder if you can comment first, maybe define corporatization for those unfamiliar, and then maybe comment, is this PE specific or is this just a broader phenomena and PE is just one example?
Great. Thank you so much for that question. I think the answer to that question holds the key to defining policy approaches that help us get to a health system that is desirable. So a couple of thoughts on that. I think corporatization, first and foremost, I see as standing on two legs. One is consolidation, sort of your traditional horizontal consolidation that we've seen for decades now reshape US healthcare markets. We've seen PE firms be really good in the context of physician practice acquisitions to increase market power, which has the policy effect of increasing prices that insurers pay and that eventually consumers pay. The second sort of leg that corporatization stands on is this notion of shareholder primacy, the idea that corporations exist to serve the interests of shareholders and investors, and considerations for patients, healthcare workers, and communities are secondary to considerations for financial investors. That to me is a distinct concern than one that results from consolidation. PE seems to be deploying both of those tools to their advantage. Some work in progress I have compares PE acquired physician practices to physician practices that either merge with other practices independent of a financial sponsor, as well as practices that get acquired by hospitals and health systems, to really get at the idea of how much of what we're seeing from a price increase standpoint is the result of PE with respect to the financial incentives compared to just consolidation at play. And that work has found that all types of acquisitions result in similar price increases across the board. There might be a difference in the timing of price increases and the nature of price increases, but we're really looking at similar magnitude of price increases across the board. And so the last thing I'll say is, just given this important question, I think it's very important for us to understand what problem it is we try to address when we discuss policy problems. Private equity is not the problem. Consolidation could be a problem, and financial engineering could be the problem. We might see PE deploy each of those differently in different sectors, but being very clear about the problem being addressed can help the effectiveness of policy approaches.
Well, thank you so much. Let me turn next to Sneha. Another thing we often hear, you alluded to, is, and Yashaswini said, you've seen one PE acquisition, you've only seen one, and the different actors. And I think one of the key things, and I think one of the important contributions your paper had is, let's look at the heterogeneity across PE firms and their behavior. It often comes back to this idea of good or bad PE. Your work highlighted the HCA strategy was quite different. Do you view HCA's approach as a model that kind of mitigates some of these common concerns, or is it equally problematic? You in your paper didn't put a value judgment on it, but I'm seeing if I can push you a little bit on that and see, as you see these different strategies, if you do view their potential impact differentially.
I agree that the potential impact is likely very differential, right? So it looks like HCA and all of the other firms attack the profit equation from different variables. So profit is revenue less expenses. And so HCA seemed to go after the revenue side. The other firms that we studied seemed to go after the expenses, the cost side. And at the end of the day, if you increase revenue or you decrease cost, profits go up. And so in that regard, it seems like the final goal was achieved. The extent to which it was achieved, I don't know. But the HCA model seemed to be increasing prices and they didn't cut staffing. However, by virtue of the HCA acquisition being so old, it was in 2006 when it was taken private, we don't know what the quality implications were. Because of a lot of data limitations, we haven't been able to look into the HCA to really see how patients fared. I would say that my guess is that some of the issues we saw with more recent acquisitions with hospital-acquired complications, transfer rates, mortality, are likely less present because staffing was not obviously cut on average from what we saw. That being said, there are inherent other problems, as Yashaswini pointed out beautifully in her talk as well, that there are consequences to increasing prices. The consequences may be different, and the time horizons on which they affect patients could be different. And the way in which they affect access to care and even quality of care could be different. But I don't think raising prices or roll-up strategies, both of which HCA was known for, are benign in that I don't think they are consequenceless. I don't think that's sort of a victimless action. And so I think the jury's still out a little bit to see how HCA's strategies ultimately affect patients. It's something I'm hoping to study, although it's one thing to bear in mind that they were the big acquisition, but it was a long time ago. And so we do have more recent information on behavior in recent years. And so studying HCA is important, but it may not be the most relevant or timely anymore.
And Sneha, if I could just squeeze in one more question before I turn to Ola and Stephanie, which is that there's often a conversation also about PE firms are evolving and they're trying new strategies. You described a bunch of behavior or changes in hospitals long time ago, 2019. If I was to look now, what is your sense? Would we see similar behavior, or do you think the model has changed and that it may not generalize to more recent acquisitions?
The classic model that Yashaswini talked about, the leveraged buyout, I think is becoming less common, especially amongst large, expensive acquisitions like hospitals. We have in other work seen that acquisitions in smaller entities like hospices are rising in the 2020 to 2025 years. But I think there are new mechanisms by which private equity is financing hospitals, whether it's owning the land or the property, or if you think back to Yashaswini's beautiful diagram, she showed that 70% of the acquisition is financed through debt. Historically, that debt comes from banks, but recently that debt is coming from private equity firms themselves. And so what we're going to see now is private equities financing these acquisitions in different ways than the typical leveraged buyout. How that actually translates from the financing to operational control, which usually also accompanies a leveraged buyout, is still up in the air. And the problem, as Stephanie also pointed out, is that a lot of the leveraged buyout in some way has some disclosure in that we know it's happened. If the private equity firms only access parts of the leveraged buyout or parts of the financing structure, it becomes almost impossible to understand where their influence comes in. And so that's going to be a challenge. And I think that's a way in which we're seeing private equity involvement and evolve and I think that'll be true over the next 10 years.
Thank you, Sneha. Let me turn to Ola, and I'm going to acknowledge a little bit unfair question, but as I heard you present and I was looking, I wanted to know if you could put your look into your crystal ball and say, what's the future look like here? Some I've heard say, we're just started here with private equity and it's just going to keep on going. And others have highlighted, well, maybe the low-hanging fruit, the certain specialties where maybe they've seen the highest value, those have been taken, and probably we're going to see a waning of private equity acquisition. I guess, what is your thought as someone who's looked in this area?
This is a great question, actually. So, an interesting one. And to understand it, there is no one clear answer, but we can look at the factors that maybe encourage the BE growth versus the factors that might actually hinder the BE growth. For example, why BE got interested into healthcare, like aging of the population, where it create increased demand, market fragmentation, create ripe areas for investments, healthcare system inefficiency, where create more opportunities for private equity to invest. Others more recent, high tech and innovations, digital health, AI. All of this new innovation could create actually a more opportunities and market for the PE to continue to increase in healthcare system investments versus some of the factors that actually might hinder, like economic factors, like what happened during COVID, operational shortage, regulatory scrutiny or public opposition. All of this actually could hinder the growth. But the fact is that private equity continued, despite all these challenges, to increase their investment over the healthcare. Sometimes they will slow down, sometimes they will peak, like in 2021 where they peaked, and then they increase the slowdown in 23 and 24. So all of this will lead to us predicting that private equity will continue. They establish their presence, so they will continue to increase, whether they slow down or increase depending on the challenges. They might navigate some regulatory hurdles, but their presence will continue.
Thank you, Ola. I really appreciate it. And it's always hard to predict the future. So, Stephanie, let me turn to you. You highlighted a couple of examples of both corporate practice and medicine laws and some of the transparency requirements. Um, I think often for those of us unfamiliar to this space, we were looking, if you looked at this rigorously, is there a specific state whose legislation or regulations, I should say, you view as particularly strong and like a model legislation or across the states?
Great question. And I imagine everyone on this panel might have a different take on what they believe is the best state legislation right now. If I had to personally vouch for one, kind of through a research lens, I would say any of the states that have pretty strong transparency laws. So the Massachusetts House law that I presented earlier today. So any kind of law that increases the transparency of the PE transactions, either through itemized billing or even disclosure of clinic or hospital debt, would improve any researcher's ability to kind of study the influence of the private equity on healthcare and costs and quality, just for us to kind of further explore the direct impacts of PE on healthcare.
Great. There are a plethora of other questions that I have, as well as I've been trying to incorporate some of the questions from the Q&A, but time is tight, and I do want to give our time to our second panel. So let me see if we can transition. So thank you all for your wonderful presentations and your work in health affairs. And if we could transition, and I'll start introducing our second panel and start, again, posing some questions from the Q&A and also my own questions. So our first panelist on the second panel is Barak Richman. Barak is the co-director of the Health Law and Policy Program at George Washington University and a senior scholar at the Clinical Excellence Research Center at Stanford School of Medicine. Second, we have Ji Bai, who's a professor of accounting, a professor of health policy and management at the Johns Hopkins University. Third, we have Rick Snyder, who's president of HeartPlace and the past president of the Texas Medical Association. And last but not least, we have Zuri Song, who is an associate professor of healthcare policy and medicine at Harvard University and an internal medicine physician at Massachusetts General Hospital. And I really want to, as all of you join, want to start, and I'll call on people individually, is to start where our last panel really kind of highlighted over and over again. What's the problem? What is the issue that we're trying to address with private equity? And is it the debt acquisition? Is it the reduction in clinician autonomy and the other characteristics that Yashaswini and others highlighted? So let me start with that question and maybe just go around. What is the issue that we need to solve here? And let me start with Barak.
I mean, look, at the risk of being banal, I think the issue we're trying to solve is we're trying to reconcile the constraints and incentives of using market forces with the delivery of healthcare. This is something that is as old as time itself. And I think that's what this is revealing. We have not figured it out yet.
And is there a specific component of the PE strategy that you, if you could rank order, you would say is the most problematic, or is it the whole package in that way?
So, that question, it almost is built upon the premise that PE is fundamentally different from other actors in the healthcare space, and I'm not sure it is. Now, again, I am very heedful of the research that the previous panelists and especially Zirui on this panel has done. The average effect of PE involvement in the health sector increases prices and has done very little to improve quality. If anything, has reduced quality, and that's a problem on the most fundamental level. Um, but we're seeing the healthcare marketplace evolve in a whole bunch of ways where for-profit entities are entering, insurers, hospitals. By the way, nonprofit hospitals, I think, are for-profit entities also. They increase prices. They exploit market power to the same degree as for-profit hospitals. And look, there's a great degree of well-founded discomfort with what any of these entities are doing. Um, so, what is the issue with PE? I think the issue is that they're participating in the healthcare marketplace, the US marketplace, in ways the same way that other entities are, and is wildly problematic.
Yeah. Well, let me turn to Zuri, and then I'll turn to G and Rick. Zuri, what do you think? If you were to kind of emphasize what are the problems we want to solve here?
Thank you, Atif. On the ground, on the front lines of healthcare delivery, the problem, I think, centrally is patient well-being and outcomes, the clinical quality of the care, and closely attached to that is clinician well-being. On the patient side, I think no matter what you think about the financial infrastructure of the acquisition and the management, at the end of the day, healthcare is human-centered at the bedside, especially in an inpatient setting, where staffing matters a great deal, as my colleague Sneha noted earlier. And I think staffing cuts as a primary mechanism for generating margin for investors and the parent firm really can have a negative impact on patient outcomes at the bedside. So a bloodstream infection, a fall, a surgical site infection, even a death perhaps in the ED as recently found, are real clinical outcomes that matter a lot for patients and their families and are the central part of why we deliver healthcare on the front lines to begin with, to preserve life and to prevent disease. And then on the clinician side, there's an emerging evidence base that shows clinicians in these types of acquisitions often lose some of their autonomy and freedom, both in observable ways and in unobservable ways. Observable, for example, in that they have a non-compete where they have to move a long ways to find an alternative place of employment. Less observable in the sense that their clinical decision-making can be influenced by financial incentives through the corporate ownership chain. So for both patients and clinicians on the front lines, I think their well-being and their outcomes ultimately are the problem we're trying to solve.
Right. And so if I could summarize what you're saying, Zuri, you're focused obviously on the outcomes, but if I was to go down the causal pathway, it's the decrease in clinical staffing and the clinician autonomy that are among the plethora of concerns, but the ones that are you're most concerned about in terms of negatively impacting patient outcomes.
Very briefly, that's just one. A second related would be the handling of debt. Managing debt on the part of a delivery system is not trivial. For frontline clinicians and their clinical leaders to manage financial debt over time to pay the interest on that debt. And if you have your land and your buildings sold from out underneath you to then pay rent to practice in the same buildings requires the ability to generate profits, often with less staffing over time, and still be able to manage the patients coming in through the door. So it is not just the staffing alone, it's also the financial weight and the pressures of the debt.
Of the debt acquisition. Gee, I wanted to turn to you. Say, one, is PE acquisition problematic? And if there was a component of the entire model that you really wanted to focus on that you see as problematic, what would it be?
Yeah, great. Thank you. First, I want to say let's also look at evidence outside of health affairs or JAMA or traditional health policy journals. So recently, we know there's a famous paper from Journal of Financial Economics. They look at a large sample of PE acquisition hospitals, and they found no evidence that PE acquired hospital more likely to close. And also they found no evidence that the quality of care changed after PE acquisition. But they did find that the hospitals purchased by PE would increase their price for colonoscopy. Why? Because that colonoscopy is not having any out-of-pocket price due to AC regulation, right? So PE is trying to exploit every loophole that they can. But if there's no loophole, they really cannot exploit on the pricing side. But on the cost side, they did reduce administrative expenses by almost a third in nonprofit hospitals, about 1/5 in for-profit hospitals. So I think this is an alternative evidence to always keep in mind that PE acquisition does not necessarily turn into bad or worse quality of care. On the physician side, they found that after acquisition, the admin staff actually got cut a lot. But physician, nurses and pharmacists, they declined. I mean, the labor, total labor amount declined, but then came back later. So just want to bring that evidence in. We should always ask, why would the PE firms buy those targets in the first place? Do they want to run the targets to the ground? We teach in business school, we know PE firms want to make money, right? So to turn a struggling target into a successful I would say, object on the market and then sell at a higher amount, that would be the success for all PE firms. Therefore, think from the incentive perspective, there's really no reason for them to intentionally make things worse. And when it comes to leveled buyback, remember, leveled buyback is very commonly used in almost all industry, and PE is not only in healthcare, right? In retail, in manufacturing, everywhere. So you have to let the PE firms to use the leverage buyback to get the liquidity. If there's no liquidity, how can we save the struggling hospitals? And by the way, most targets are struggling. So PE firms try to buy low and then sell high at a higher amount. Finally, I want to make one point. At the end of the day, we have to ask, why do these independent physicians or small hospitals are willing to sell themselves in this voluntary transaction, right? Nobody's forcing them. They're voluntarily selling themselves to PE. So in my opinion, it's because the soil has been made so toxic by policy failures, giving an advantage to large entities. So large entities can only survive. So small ones cannot. So they have to be forced to sell themselves to either PE or large health systems, And so at the end of the day, there's really no good players or bad players. Everybody's here for the money. So I have done work in nonprofit hospitals. Can we say nonprofit hospitals just morally superior? Probably not, right? So everybody's just here of competition. I think PE is actually a healthy dose of competition to the market. Thank you.
Yeah. Before Rick, I'm going to ask you that question that G just posed in a second, but before I turn to you, let me just add one follow-up question, G. So what I'm hearing from you, and please tell me if I had this wrong, is you view the PE entry into healthcare as a positive change. And so I wonder if you could articulate for the audience, what is the positive benefit of PE acquisition in healthcare that you are really focused on to say this is, again, a societally positive or development, because many others disagree with that.
Thank you so much. So if, let's say, we ban any PE tomorrow, now two questions come up, right? Number one, what to do with the struggling hospitals? Let's say I'm a CEO of a struggling hospital. I'm looking for buyers, right? Now, because there's no PE ban, how can I find alternative buyers? So to me, the buyer's market shrinks. So eventually, I think the chance for me to go bankruptcy, to close my door, is actually higher. Let's say if the community does not want me to close, what do? They use taxpayers' money to support me. Eventually, taxpayer is at the hook. Right, so that's something we have to keep in mind. And second, we want the competition as long as the entrants are not protected by the government, right? If let's say I'm a monopoly, my brother is a government, and I use certificate of needs law or all those regulatory captured provisions to kill all the competitors, that is bad. But if I'm just coming here, voluntary transaction, you give me money, you give me your entity, and I give you money, everybody, nobody's forcing anybody, I think that's actually helpful. In fact, some of my students at Johns Hopkins, they are MD, MBA students. Some of them have a great idea on how to run hospital. They would come up questions like, Professor Bai, actually, I know there are a lot of redundancies in whatever hospital. I want to make it better. Then what should I do? without I telling them, they actually got the answer. That is to find PE capital. They might want to run PE. I think that's actually add to the innovation force, actually can help the young entrepreneurs, innovators, great physicians to find a way to really reintegrate many hospitals. Thank you.
Right. Thanks, Yi. Well, I'm sure we'll come back to this. I think it's an important topic, but I want to add Rick to the conversation. Rick, I thought I'd get your thoughts, perspective, and actually don't know if Hart Place also is PE acquired. So that might be another thing that you can maybe touch upon if you wouldn't mind.
Is actually part of a national PE-backed MSO platform. And we actually had an MSO before we became PE-backed. But let's get back to the question we're trying to solve for. Number one, cost. If you look at CMS data that comes out yearly, last year we spent $4.9 trillion as a country. By 2033, we're going to be spending $8.5 trillion. It's going to be 73% higher. And on a per capita basis, we spent $14,570 per capita in this country. Easily number one in the world, and almost we outspend almost every other country by 2 to 3 times. So this is not an insufficient spending issue. It's a cost efficiency issue, largely driven by the Medicare type population. So we as physicians need to be at the head. We need to be a physician-led solution to introducing cost efficiency, to the extent that cost is going to be the number one barrier going forward. So I actually agree with you. Private equity is not the problem, but I actually believe it's going to be a large part of the solution. So why do I say that? So I actually participated in the U.S. Budget Committee hearing in May, and the title of that hearing was Breaking Up Healthcare Monopolies, Examining the Budgetary Effects of Healthcare Consolidation. And the consolidation that they were focusing on was not private equity, it was hospital physician consolidation because of the dynamics of sited care shifts. So really the question we should be answering and asking ourselves is not so much the PE model, but the independent model versus the hospital affiliate model. And the question is, does physician affiliation impact healthcare expenses? And the unequivocal answer is yes. It does impact healthcare expenditures by site of care dynamics. And I'd like to also point to another study that was outside of health affairs that was conducted by Avalere. And what they did in that study, they looked at 5 specialty groups that were all Medicare providers: cardiology, GI, medical oncology, orthopedics, and urology. And they looked at every Medicare provider. So it wasn't just a sampling, it was every provider. And they assigned them to affiliation, either hospital affiliation, corporate affiliation, private equity affiliation, and unaffiliated private practice. And to no big surprise, the unaffiliated model is going away and they're migrating to one of the other models. And actually for these groups, for example, in cardiology, it's 1% of the 20,000 Medicare billing cardiologists in the country. And during that same time, from 2019 to 2022, while private equity went to 1%, the hospital affiliated actually increased 3 to 4%. So now that market trend is not a surprise to anyone on this call. But what is the impact on total Medicare expenditures per beneficiary per year by that affiliation model? And it's no big surprise the hospital affiliation model is significantly higher than the other 3 independent models, independent being not hospital affiliated. For example, the private equity was 26,377. The unaffiliated was 26,303. And when you look at quality and utilization parameters, for example, using total inpatient days per beneficiary, the hospital affiliated model, it was 5.04 days per beneficiary inpatient versus cardiology, for example, was 4.04. In terms of total ED visits, it was 13% less with the private equity affiliated model. And as a whole, for the independent model as a whole, it was about 10%, 10 to 13% less.
So Rick, apologize for interrupting you, but just to clarify your thinking and just make sure I'm following you, you've articulated why hospital acquisition of private practices could be problematic in terms of increasing prices. But this is also about PE. Does that imply PEs should be encouraged or discouraged? And I wonder if you could really speak to, I'm hearing from you on a relatively positive perspective that acquisition by a PE firm on the clinician side is okay, but then many of the questions here, as well as some of the other literature, has highlighted that if I'm in a practice as a physician that's PE acquired, it's a pretty negative experience. So I wonder if you can square that for us and the audience as a whole.
Actually tip that up. It's been a very positive experience for me. One of my roles as president of Texas Medical Association was go throughout the state on a weekly basis, meet with every academic center, meet with the different hospital centers, President Texas Hospitals Association, and I could actually feel some of that frustration with those individuals. But the reality is, when you are an independent entity, you still are leveraging those low-cost sites of service. When you become hospital affiliated, you tend to more use those higher costs of service. So, for example, in my office, I'm sitting in my office, I saw some patients today. Dallas County Medicare allowable, for if I do an echocardiogram, it's $132.27. If I take a magic elevator ride down one floor to the hospital outpatient lab, it's $503. For my group alone, we have 60 doctors. If we became hospital affiliated, the increase to the Medicare system would be $8.6 million a year just for that one procedure.
And I think the issues of site of care and site of neutral payments are a really, really critical one. I guess one last question, then I want to turn to Zuri to kind of get his take on this from a different perspective. The literature has highlighted decreased staffing as being a major issue. Zuri highlighted that. It sounds like your experience and your members haven't really experienced that in Texas, that this issue, just fewer people to take care of patients with PE acquisition.
No, we've been part of a private equity associated group now for 2.5 years. We've had zero change in our commercial rates. In fact, we've staffed up to a certain degree, and that we now have the administrative bandwidth and the financial bandwidth to build innovative value-based care centers, for example, heart failure specific clinics that provide immediate access to heart failure patients, because that's one of the number one issues and costs to the Medicare system. We were not able to do that beforehand. And now we're able to do that, leveraging some of our low-cost sites of service, like our ASCs, like our ancillary services. And I was actually able to host Congressman John Joyce about 3 weeks ago. He actually hosted him, and we actually came to my office, and we actually went to our hospital complex, and where our ASC is on the 6th floor and the hospital outpatient is on the 1st floor, and we took a magic elevator ride up to the 6th floor of the same complex, where that same procedure that was performed in the hospital outpatient department was about $5,000 less. I park at the same parking lot, the patient parks at the same parking lot, and just by the investment of taking that elevator ride. So one of the things with the big CEO for one of the commercials say, they actually like private equity because it keeps them independent from hospitals.
Yeah. And again, I just do want to emphasize that there is a larger debate outside of this conversation about PE, which is on site of care, site neutral payments, and the issues that you're describing. Zuri, I wanted to turn back to you. G and Rick have painted with a relatively positive light PE acquisition. I wonder what your thoughts are on their comments, and also what your research has shown.
This is a great discussion. This nuance is exactly what I think can be informative to policymakers and the public. The impact of private equity is not uniform or monolithic. And within the different segments of the healthcare delivery system, you can have different effects. When Rick and G mentioned the impacts on physician practices are incredibly heterogeneous across over 100 specialties in our country. There are many types of outpatient facilities that treat specific health conditions. And the impact of private equity there can be felt through staffing, through the financial investment, through the purchase of EHRs, through the purchase of other things that clinics need. So the financing certainly can be important. And it happens to be a type of setting where patients generally don't face mortality. They're generally not at the end of life or acutely ill or in a hospital setting. So in a setting where patients walk in and generally walk out, indeed, some of the hospital-based clinical impacts you wouldn't expect to see. But on the hospital side, we should still have our eyes wide open about what staffing cuts mean. So just to be concrete, staffing cuts on average in acute care hospitals range between 16 to 18% in the ED, about right around that number, 17% hospital-wide on average, with a variation across hospitals of roughly 12%.
This is with PE acquisition.
Yeah, after PE acquisition, within the first 3 years, staffing cuts ranging from roughly 12% to 27%. And if you look at total FTEs, that's roughly around a 12% cut. So there's both a cut in staffing expenditures per staff member, as well as a reduction in the total number of staff. when our colleague G here noted the study within the finance literature that claimed there were no impacts on quality of care, I think it is important to just highlight that in that study, they looked at only patients who are 35 to 44 years of age on average, and the outcomes measured were deaths from heart attack, heart failure, and pneumonia. Within that young of a population, not only do they rarely get heart attacks and have heart failure, but to die from those conditions is even more rare. So one would not be surprised to find no effects on those outcomes in such a young population. I think finding no effects in such a young population does not mean that the staffing cuts and private equity acquisitions have no effect on health or clinical outcomes for everyone else. And in fact, when you look at an older, more vulnerable, sicker population, like our Medicare population, that is where you find the clinical adverse events and the mortality. And in our nursing home population, our colleagues at NYU and Penn have found a roughly 10% increase in mortality relative to control after private equity acquisition. So the setting is really important. The patient population you look at is really important. And I also want to note, our colleague, Professor Bai, mentioned that the hospitals and facilities are all distressed. I think this is an incredibly compelling pushback and one that we need to be really careful about studying and assessing. Is it true? And one of the answers in the Q&A mentioned this as well, that before acquisition, private equity firms are really trying to save distressed entities. If that were true, they deserve credit for that. And there are indeed cases and anecdotes of distressed investing where private capital can come into a community and save a struggling facility, keep it open while still generating a profit. And it's sort of a win-win-win for patients and community access and the firm as well as the facility. But the latest research to date, in my opinion, argues that on average, that is not true. On average, such as a study I put into the answer in the Q&A, at least for hospitals, the hospitals that get acquired are actually financially healthier at the time of acquisition than their matched controlled peers who did not get acquired, which should make total sense if we think about the financing model of the leveraged buyout, no matter where the risk or the debt is coming from. And that's because if you're going to place new debt onto an acquired entity, who would you rather place it on? A hospital or nursing home or facility that's teetering on the edge of bankruptcy or closure, or one that's financially healthy enough to handle additional debt and still generate revenue for you and still continue to operate? It makes total sense that on average, you would rather place new debt on the slightly healthier facility able to handle it than the facility that's about to go under. And so on average, this distressed investing narrative is likely not true. And outside of healthcare, there are many, many examples in manufacturing, service sector, consumer goods, where also on average, it is not true. But we should still recognize the few rare instances where distressed investing has worked. So both can be true, but on average, the distressed investing narrative, at least in healthcare, has not been the widespread case.
Well, we've had a really good conversation about the topic of the impact of PE acquisition on clinical care. Is it positive? Is it negative? We've talked about that, and also the issue of which hospitals might be acquired. There has been agreement, it appears, across the four panels, and please all of you disagree, that PE acquisition has led to increased prices. And there are different perspectives on, Rick, Barak, you jump in. Do you agree with that comment? Then I'll let Rick jump in because Rick's shaking his head the other direction. But is that true or not true? I was highlighting some of the research that I've seen where I have seen increased prices, but please others should jump in if they disagree. But go ahead, Barak.
So look, let me begin by saying I approach this problem as an economist, as an antitrust attorney. I am all with G that certificate of need regulations are any competitive and problematic. I'm 100% with Rick in agreeing that there are real problems with hospital acquisitions of physician practices, all sorts, not just on competitive problems, but also regulatory problems. And look, I do think that part of this conversation has to begin with the observation that the independent physician has become a rarity, whereas only about 15 years ago it was the norm. And that's a real problem. And most of the demise of the independent physician has come from hospital acquisitions, but it's from a bunch of other things also. That I think is actually a real shock to our system and is something that really needs priority concern from policymakers. So I'm sympathetic to, and always have been, to the possibility that PE can preserve physician independence, can bring in outside expertise, managerial expertise, can inject competitive dynamic, additional competition into the marketplace. I have been open to those ideas from the beginning. And look, I think the reality is that the literature is suggesting that it's not working. On average, it's just not working. Now, does that mean we ban Look, I'm delighted to hear that it's working with Rick's practice. And as Zuri said, it's working in a lot of places. But when I say it's not working, we are seeing a reduction in quality. We are seeing increase in prices. And what's fascinating is that we have to distinguish between prices and costs. I also am all in with Rick's first comment, which is that the problem with American healthcare is not that we have reduced staffing. The problem is that we're spending too much. And I am, again, open to the possibility that PE can be a solution to that. But when we think of, I guess, the trifecta of effects on costs, bringing costs down, which PE does fairly effectively throughout the economy, but an increase in price and a reduction in quality, that's something that really needs to be, well, at least further studied. I remain in principle an enthusiast of bringing in outside investors and bringing in new managerial expertise, new technologies to really understanding how we can get greater value from our healthcare delivery system. But I'm also convinced by the empirics that we haven't done that yet, or PE has not done that yet. I personally would like to think that the next step is to understand what the problems are with greater specificity. I'm not an enthusiast of expanding a corporate practice of medicine doctrine. I am an enthusiast of more research, but I really would love to have G and Rick at least concede that the research is telling us we should be doing a lot better.
All right, Rick, I want to turn to you a little bit. Yeah, you were shaking your head vigorously, so I want to hear. So again, to frame the question for you really quickly here, which is the maybe I'm wrong too. Perception of the literature is that on average is increasing prices, but you shook your head, so I just wanted to get a sense of why you disagree with that.
Let's get back to the basic benchmark. Is the quintuple aim: patient experience, cost, population health, physician experience, provider experience, and health equity. I'm going to again refer to the Avalere study. And when we looked at those 4 different affiliation models, and we looked at what happened, because we all know independent private practice, 100% owned by the physician, that is migrating away because of the different financial, administrative, and regulatory burdens. But what happens when they go to one of those 3 models? In that same study, to our surprise, for all 5 of those specialties, it went down significantly. And specifically for cardiology, on a per beneficiary per year total Medicare costs, it went down $1,023. But to the other 2, the corporate affiliated and to the hospital affiliated, it went up. So and again, I still look at these, I still look at myself as an independent practitioner, because I have the option to take and choose which hospital I want to go to. I'm not tethered like a ball and chain. So one of the bigger cost reducers is choosing the low cost site of service, whether it be hospital A versus B or that place of service. I actually have that. And some of these sentiments are actually echoed in the GAO report that actually came out a month ago, where they actually say studies indicate that physician consolidation with hospitals can lead to increased spending and prices. And they specifically mention this consolidation and limiting the site of care dynamics they can use, where they do not have the same availability and access to low-cost sites of service like an ASC or a hospital or an office lab. And when you listen to Chris Klomp, the director of Medicare, I actually had a chance to interview him about a month ago. He was very clear. Our goal is simple: deliver the better outcomes for patients and be wise stewards of the taxpayer resources that make Medicare possible. And in his comments on the final rule that came out on ASCs, he says we continue to advance Medicare payment reform by advancing policies that help prevent services from unnecessarily being performed in the hospital setting when it can be safely provided in less intensive settings. So I think our policymakers are beginning to get that. When I showed Congressman Joyce around our facilities, And he got to take that magical elevator ride with me from the first floor to the sixth floor. And I had done a case that morning. If I had done it on the first floor, it would have been $11,000 put in that stent. It would have been $5,600 on that ASC. And the employed physicians whose offices is right below don't have that access. I have that clinical autonomy to the extent private equity helps keep independent physicians independent. This is part of the solution. We too should be taking a much closer look and look at the impact on cost and cost savings.
So I want to turn to G because I feel like she needs to weigh in here, but I just wanted to clarify my thinking, Rick, just because it's really important. Tell me if I have this wrong, but what I'm understanding from you is that your thought is that we shouldn't be comparing PE acquisition to remaining independent because remaining independent is not viable. And so we should be comparing PE acquisition to hospital acquisition. And in that context, PE acquisition is not as bad as hospital acquisition in driving prices because the hospitals can exploit this point of service kind of magic elevator analogy that you've raised.
Look at, especially on the
you muted. I'm sorry, Rick.
You can't look at that as a physician. You can't look at that in isolation because we know we're getting this relentless migration away because of those factors. And when you listen to the AMA, they did the survey again last year. Why is private practice being sold? And they said 70.8%, very important or important, for better negotiating higher payment rates. They're under financial stress. Number two, 64.9%, very important or important, improve access to costly resources, i.e. capital. And then finally, 63% better manage payers' regulatory and administrative requirements. That's what an MSO does. And at the end of the day, value-based care, which I think we should all embrace, is played at scale. If you're a onesie or twosie, you don't have the administrative or regulatory or financial bandwidth to really provide success in that type of access to our patients.
Yeah. So Rick, sorry, and we're looking at the time, we're running out of time, and I've neglected G. I wanted to let you have a chance to weigh in on some of the conversations about both the evidence and also the specific issue, maybe on the cost implications of PE acquisition.
Yeah. Thank you so much, Atif. Think about if you are CEO of a PE firm, what would you do? How do you make money? Very simple. Buy low, sell high. So you want to buy a target at a low price. Does not mean the target is going to go bankrupt tomorrow, but means that the market valuation of the target is lower than its potential, right? So that's why almost all the targets have a cost redundancy. So PE go there to revamp and then make it more lean. And then when you sell, you want to sell at a higher price, right? How do you do that? Can you afford to run to the ground? Let's say low quality, very high price? No, you won't be able to do that. So you're going to adjust the price so that the hospital make money. Does that make sense? So if you make a very high price, then the market share shrank, then you lose your market share. You won't do that. So everything's regarding this buy low, sell high. So if you understand that,
but if I could push you a little bit, the anecdotal experience that we're seeing in so many states is not this buy low, sell high. It's the hospitals going under and the state having to come and rescue them. That's the conversation that's happening in Rhode Island. So I'm curious, how do you square that a little bit? I love conceptually what you're saying, but right now the residents of this state are quite upset that the hospitals that they love are now going under.
I think two reasons. One is bad apples get more coverage. Right? Bad apples get more coverage. And good apples don't get coverage, like Rick's experience. Right, that's what's happening. And also, many politicians with their connected hospital systems or insurance systems try to push PE out. The PE is going to be a threat to them, right? Because it's increased competition. So my message to our audience: if you have a great idea, you have a way to totally revamp a hospital, make it more lean. Find a PE where you become a PE. My best students want to go to PE, and they really want to help patients, and they're very smart.
May I give a quick
comment?
Zuri,
if you could have the last word and then we'll have to end.
Okay, thank you. I actually think the four of us agree on the goals as I listen to everyone here. I think we would all agree that we want our patients to do well. We don't want to see patients harmed. I think we all agree that we want physicians to feel the autonomy to practice medicine in their evidence-based way, and that the influence of corporatization and the burnout that's felt could perhaps have an alternative that's better if the financing mechanism were different. And I am compelled by Rick's personal example from his practice. I think there's a world in which, as we just talked about, it's possible to get more of the good and less of the bad. I think being nuanced about where the good and the bad reside in each sector of the delivery system is incredibly important, so we don't speak about this issue with too broad of a brush. At the same time, where the evidence is compelling with large database samples showing average effects that are concerning, we do have to think about appropriate policy guardrails in those instances. Other countries have taught us some of the lessons of what guardrails can do. The US remains in a setting where we have very little to no guardrails around private equity in healthcare. Private equity has succeeded in many other industries in G's terms. They have made money, they have succeeded for their investors, but in many of those industries, they are a little bit more arm's length away from bodily harm of the consumer. The consumer here is the patient in healthcare. That's qualitatively different. If you're making a consumer good, if you're building a product and the consumer is downstream, then cutting staffing or financing things differently or placing debt and having things go under, it doesn't kill anybody right away, at least. It doesn't affect your consumers in that way. It doesn't give them a bloodstream infection. It doesn't give them a fall or a surgical site infection. But in healthcare, it's a different thing because consumers are right there, right in front of you, and the hands on deck matter. I think in the healthcare system, we just have to always remember that nuance is really important, that right now we still know relatively little about the broad effects of private equity across the delivery system, especially in the outpatient side. But with what we have learned, I agree with you, Atif, there is cause for concern. And I think that is why policymakers around so many states and even at the federal level are trying to respond.
Yeah. Well, thank you very much for focusing on the patients, a critical issue. I want to thank the first panel for presenting their work so nicely and their work in health affairs. And thank you all for the second panel and your rich comments. Thank you all for who's attended. And you can find out more information about other events on health affairs, about health affairs events on the website, healthaffairs.org. And thank you again to all our panelists and our audience, and we are adjourned.